little bit less than 10 minutes now, but I wanted to, well, let me introduce the speakers first, and then we can go from there. So Dr. Gonzalez-Martinez is a neurosurgeon at University of Pittsburgh. He's a professor of neurosurgery and director of the Epilepsy and Movement Disorder Program. Very busy surgeon, over 3,000 surgical procedures for functional neurosurgery, which is pretty astounding. He's also very renowned in the research realm. He has over 230 peer-reviewed publications, and he's on several executive committees of some of our societies. Our next speaker is going to be Irfan Ali, who's at Texas Children's. He's been on the Baylor College of Medicine faculty since 2015. He's a pediatric epileptologist, and he is the director of the neuromodulation clinic at TCH. And he'll speak to us about palliative surgery. And then my good friend Amza Ali is director of the Comprehensive Epilepsy Center at Andrews Memorial Hospital in Kingston, Jamaica, and the head of neurology at the Kingston Public Hospital and senior associate professor at the University of West Indies. I'm trying to get him to invite me to be a speaker at the University of West Indies. He hasn't done it yet, but but I would also like to, since I have a few minutes, I would like to talk about maybe a few concepts regarding palliative surgery. I have a couple slides here. So with palliative surgery, so I'm a neurosurgeon, right? So we're very binary. It's like good, bad. So with palliative surgery, I've always thought about it as something that doesn't work too good, okay, as opposed to where we go for the home run with the resective surgeries. But really, as I advanced in my career a little bit, I began to realize that really the decision-making regarding resective surgery versus palliative surgery was based on risk, okay? And surgical risk can really be two types of risks. There's obvious surgical morbidity. Are we going to hurt the patient? But also there's the risk of the surgery not working. The patient went through the risk of morbidity and the surgery didn't work. So when we have this decision-making on what type of surgery to offer the patient, we need to balance those two risks, morbidity and lack of efficacy. So when we do that, the lower risk patients are actually the patients that we prescribe definitive resective surgery, because this surgery has a very high efficacy typically with acceptable morbidity. But the higher risk patients, those are patients that the surgery has low efficacy and low morbidity typically for the neuromodulation procedures. We push those patients towards palliative surgery. But there's some special circumstances. So corpus callosotomy is the traditional palliative surgery before we got all the neuromodulation technologies. But it's really not a palliative surgery. It really has characteristics of both a lower risk patient and a higher risk patient. So for example, patients with atonic seizures, it's like the resective surgery. It's very, very effective at stopping atonic seizures. It's curative in a lot of cases with acceptable morbidity. But other seizure types, while it does improve seizure control, it has relatively lower efficacy. Now, yesterday we learned just improving seizure control really has a profound effect on patients' mortality, on their quality of life, obviously. So I'm not playing that down, but I'm just saying corpus callosotomy, while traditionally considered palliative, maybe it really isn't a palliative surgery, especially for some seizure types. And then laser ablation has really opened the door for palliative surgery. So as Dan Curry was saying yesterday, it's people call it minimally invasive. I like to call it minimal corridor. So we can get to targets without disrupting normal brain tissue. So it tends to be a very, very low risk procedure. For some patients, it can be a real home run. So, focal cortical dysplasia, a small focal cortical dysplasia has very high efficacy with very low morbidity. It also allows us to go directly to phase 3 for patients. It's not uncommon for me to see a kid, let's say, focal cortical dysplasia, and say to the parents, look, why don't we try this, one-stop procedure? It's very low risk. I think we have a good shot at stopping the seizures. But if we don't, we can always go back and do a more traditional surgery. And so families tend to go for that. And then it also opens up surgical options for non-traditional patients. An example of that would be a patient with multifocal epilepsy. And the only downside of doing lit procedure is you got to sit with your epileptologist in the MRI suite. And then he's like, bro, neurosurgery is easy. All you do is click the button on the mouse. And then, I don't even know what to call this, reverse palliative surgery. These are patients with either new onset seizure or seizures controlled with one med, and they have a benign lesion, like a cavernous malformation. I'll tell you, a lot of families go for the ablative procedure because it is low risk. And then I gotta make a plug for where I'm at. I'm in San Antonio right now at Chris's Children's. It used to be called Children's Hospital of San Antonio. We're building a nascent epilepsy program. Last year we did 27 surgeries, and we have 2 epileptologists now. Fred Perkins, who used to be part of the band at Dell Children's. In fact, I used that on him. When I got there, I called him up. He was in Arkansas, and I said, Fred, we got to get the band back together. So he joined us, and so we're moving forward. And so without further ado, Dr. Gonzalez-Martinez, please. Oh, by the way, he's going to be on Zoom. He saw how cold it was in Austin this weekend, so he said, I'm staying in Pittsburgh.
Can everybody see me? And listen, hear me? Yes? Okay. Thank you so much for the invitation. It's a pleasure. Unfortunately, I was not able to be in person in Austin, but it's a tremendous pleasure for me to be with you at the Dell Hospital and the outstanding program you guys are developing there in Austin. The organizers, David and the group, asked me to talk about invasive monitoring epilepsy and what's the rationale in practice. So in the last 20 minutes, we'll attempt to illustrate for you why we're using invasive monitoring and some examples, in particular related to the pediatric population. The first thing I'd like to express to you is what is the scope and in general what are the indications of invasive monitoring, and this is probably the most important piece of information from this talk. So we indicate invasive monitoring in epilepsy surgery when there are discrepancies between clinical and anatomical data. When the data that we collect from a non-invasive aspect, from electrophysiological aspect and semiological aspect, they don't fit with the anatomical data, and that is one of the possible indications for invasive monitoring. When there is early involvement of functional cortical areas by semiology, this is also an indication for invasive monitoring, so we can perform a tailor resection and a safe resection so we can preserve the eloquent cortical and subcortical areas. And of course, the goals of invasive monitoring would be to localize what we call the epileptogenic zone, the areas in the brain responsible for the organization of the seizures, to localize the functional areas in the brain so we can perform a tailor resection. And finally, a detail that we forget many times is also to define the extent of the epileptogenic zone, not only to define the location of the EZ, but also what will be the extent of the EZ. And for that, we have available several different types of techniques and methodologies to perform invasive monitoring. This is probably the most wide known method in the United States and North America in the past. This was a subdural method where you do a large craniotomy or craniotomies and you lay down superficial electrodes in the cortex. And this can be associated or not with the implantation of DEPS electrodes in a semi-stereotactic fashion. And the other method that we described in the past, it's been very popularized recently in North America, is what we call the SEEG or stereoelectroencephalography, which is the placement of DEPS electrodes through a percutaneous technique that is always guided by a very strong hypothesis of implantation. And this is an aspect of what SEEG is. So historically speaking, it's always the question about when we use one method and other method. And we need to rely also on historical reasons for that. So this is a picture in around 1950s in Montreal Neurological Institute, when we see here Jasper and Payfield performing an awake procedure in a patient with focal epilepsy. You can see here Penfield looking at the brain, doing his stimulation and performing the functional mapping. And again, Jasper in the back of the room here analyzing the interdictor activity from this patient. So this is the basis of the subdural explorations, which value, as you can see by this picture, functional mapping and the mapping of the epileptogenic zone in a two-dimensional aspect, or it means at the surface of the cortex. Almost at the same time, we have here the other method of exploring those patients, which is the stereostatic electroencephalography. Here is a picture almost at the same time in Paris at the Sainte-Anne Hospital, when we can see here Banco and Talerac performing an SEEG evaluation in the operating room in a patient with focal epilepsy. But the first thing I would like you to understand and realize this is that very differently, just Penfield is looking very attempted to the brain anatomy and to the location of the mapping, and Jasper is looking at the interdictor spikes. And you can see here that both investigators, Banco and Talerac, are not looking at the brain, they're not looking at the interdictor spikes, but they are very attempted to look at the patient's face. It means looking at the patient's semiology. And that is the main fundamental difference between SEEG and the methods applied in the Montreal Neurological Institute during the same time. The value of what we call anatomo-electroclinical correlations to understand the semiology, when it happens, in the brain, in what location, and what they are the icto-electrophysiological markers that define the epileptogenic zone. For that, the stereo explorations, they favor what we call the anatomo-electroclinical correlations of the seizures, of the seizure organizations, and also the mapping or the exploration of the epileptogenic zone in a three-dimensional aspect. So those two procedures were done in the open room, and from those, they evolve from an extraoperative mapping when we have the implantation of subduros, and the SEEG, another extraoperative mapping with the implantation of DEPS electrodes. But that is the birthplace, and that can illustrate quite nicely the difference between the two methodologies. I'll give an example where and how explorations in the SEEG for lesions, resection of lesions, can be very tricky. And we need to be careful, especially in the pediatric population. This is a young patient with an MRI showing here. You can appreciate the decrease in volume of the right side temporal lobe and also a decrease in volume of the mesotemporal structures. This patient had seizures that are fundamentally what we call temporal lobe epilepsy, with scalp EG showing temporal lobe interdictal and ictal spikes. So this is probably what we call mesotemporal sclerosis. Probably this is a mesotemporal lobe epilepsy. And what we performed was what we call a standard temporal resection. This is the name we use to for a variety of procedures that we perform in epilepsy surgery. It's standard temporal lobectomy, which is a name that I don't completely agree. But we did a resection of the neocortex and the mesotemporal structures. And then finally, we send the piece to the pathologist, and the pathologist confirm there is a decrease in pyramidal cells in the hippocampal formation, again, confirming what we are suspecting before, which was the hippocampal sclerosis. But unfortunately, this patient did not become seizure-free, which is very strange. In fact, if we follow the rules, we see a lesion, we resect the lesion, we confirm the lesion, and those patients should be seizure-free. But when you analyze the natural history of those patients, you can see that there is a high rate of recurrence of those patients in mesotemporal lobe epilepsy when you base your resections based on the lesion. And when we follow those patients during a long period of time, we're talking about 10 or more years, you can see that only 50% of those patients will become seizure-free, will remain seizure-free. So there is a fundamental error in defining the planning of resection related to patients with, specifically to mesotemporal lobe epilepsy, that are only based on the evaluation of lesions, because you can see perhaps treating the lesion itself is not enough for those patients to become seizure-free for the rest of their lives. This is another example. You can see here a patient with a very clear mesotemporal lobe epilepsy on the lesion, on the MRI, preoperative MRI. And this patient was operated by my friend Jean Régis in Marseille. What they did was a very selective ablation of the mesotemporal structures using gamma knife method. And you can see here, this is the post-gamma knife methodology, post-MRI imaging, showing the very precise, completely treatment of the mesotemporal structures. And again, this patient did not become seizure-free. In fact, his seizure semiology continues to be the same. He was implanted again, or one more time, with SEEG electrodes. And you can see here that in this particular case, the seizures are in fact not completely organized on the mesotemporal structures where we were treated, but also organized on the basal temporal areas, specifically on the entorhinal cortex, as you can see here. So in this case, the epileptogenic zone was much more broad distributed than the lesion itself. And once we perform a resection of the neocortex adjacent to the hippocampal formation, this patient now becomes seizure-free. The reason that we fail many times is that we have the assumption that hippocampal sclerosis is equal to mesotemporal lobe epilepsy. And we run to those patients to do the resection of this hippocampal sclerosis. But in fact, this is not necessarily true in our patients. And we need to question this knowledge that a lesion is equal to epilepsy. We don't treat lesions, we treat seizures. And to make this assumption that lesions are equal to seizures or epilepsy is dangerous and will result in failures in epilepsy surgery. The reason for that is that we all know this is a very complex network, that the hippocampal is connected to structures within the temporal lobe, with other structures in the neocortex, and also structures outside the temporal lobe. So I would like to highlight the red flags of mesotemporal lobe epilepsy and hippocampal formation and hippocampal sclerosis, when the presence of some features can perhaps highlight or raise the flag that perhaps the lesion does not tell the whole story. The absence of febrile seizures is a red flag that we should be concerned. The presence of secondary generalized tonic-clonic seizures is also another concern. Pure mesotemporal lobe epilepsies or pure hippocampal sclerosis causing mesotemporal lobe epilepsy, in general, they don't develop secondary generalized tonic-clonic seizures. The typical history, atypical EEG, head trauma, encephalitis, and of course, when we fail a selective myelopatectomy, those are red flags that should raise the question that the lesion does not tell the entire story. Sorry about the technical issues here. I pull back a couple of slides so we can follow the discussion. So again, for lesional temporal lobe epilepsy, anatomical electrical correlations to us is essential. And I'll give a couple examples of similar lesions explored with SEEG. This is what we can see here with a very well organized and restricted epileptogenic zone that are located in the amygdala, hippocampus, and the entorhinal cortex. And this is what we call a pure mesotemporal epilepsy, mesotemporal seizures coming purely from the mesotemporal region. And for that patient, the surgical treatment should be tailored to resect or to treat or to ablate the mesotemporal structures, including the parahippocampus, and that patient should become seizure-free with that. However, we have a very similar patient with a very similar history, with a very similar lesion on the MRI, with a slightly different semiological features. And here, when we perform SEEG, you can see that the organization of the seizure is completely different, not only restricted to the mesotemporal structures like the anterior hippocampus or the entorhinal cortex, but also well organized in the fusiform gyrus. And this patient requires a different surgical treatment, and not only the resection of the lesion, but the extension of this resection or this treatment towards the basotemporal areas in this region in association with the mesotemporal structure. So a little bit different surgical strategy, purely based on semiological features and not too much on lesion. So for that, we believe that the SEEG is a very comfortable or very pertinent method that we can better understand the organization of the seizures and perform tailored resections based on that. So there are there's several variables defining the application of extraoperative invasive monitoring or not. And to be practical, we can divide those groups in two, basically. The one that we call lesional MRI, and in patients with lesions on the MRIs, we can perform or not invasive monitoring based on several data. For example, the location of the lesion. If this lesion is located in the mesotemporal structures or outside, this will define the utilization of invasive monitoring or not. The presence with the proximity of this lesion with eloquent cortex also will define the utilization or the indication or not of invasive monitoring. The suspected etiology, it's very, very important when we talk about malformations of cortical development versus mesotemporal lobe, mesotemporal sclerosis versus vascular malformations. The etiology will change the indications or not of invasive monitoring. The duration of the epilepsy syndrome also is an important factor. The longer the duration of seizures, the most likely the widespread of the epileptogenic zone and likely the need for invasive monitoring. And finally, what we've been highlighting in several slides is the presence or not of the anatomical electrochemical correlations with the lesion MRIs. When we talk about non-lesional MRIs in our service, all those patients require invasive monitoring with very, very few exceptions. So let's go some examples of lesional MRIs with adequate anatomical electrochemical correlations. This is a patient with a lesion in the temporal pole, oligodendroglioma that affects the mesotemporal structures, patient with a mesial temporal lobe epilepsies with right side interictal and ictal spikes. And for this patient, the requirement treatment is a direct resection of the lesion guided or not by ECOG. This is another example of a mesotemporal lobe sclerosis in the left side with adequate anatomical electrochemical correlations, and both patients will require resection of the mesotemporal structures with or without the neocortex guided by ECOG without the need for invasive monitoring. But let's see this other lesional case that requires invasive monitoring. This is an extra temporal lobe epilepsy patient with auditory auras with scalp ictal and scalp EEG, ictal and interictal showing left side temporal interictal spikes and ictal recordings, and an MRI that shows a contralateral right side occipital lesion with atrophy, probably encephalomalacia in the occipital areas on the right side, on the contralateral side. Clearly, this patient does not have visual auras. Clearly, the EEG is located on the contralateral side, and despite the presence of a lesion, an invasive monitoring is indicated in this patient in order to better understand the extension, the location of the epileptogenic zone, the extension, and also the contribution of this contralateral lesion into the organization of seizures. And that's what we did. For this case, there are discrepancies in the anatomoelectric correlations. The question is the contribution of the lesion, the extent of the epileptogenic zone, and the interactions with functional cortex, since the left temporal is a dominant side for this patient. This is additional non-invasive data showing a MEG scan, showing the presence of MEG dipoles located on the planum temporale hash gyrus on the left side. And for that patient, we perform SEEG exploration on the posterior perisylvian areas on the left side, and also the explorations of the lesion on the contralateral side. And what normally the way we implant, this is an anatomical specimen showing the implantation of orthogonal electrodes to explore the superior temporal gyrus, with one orthogonal electrode in the plenum polari, another one in the dorsolateral aspect of the hash gyrus, and another electrode in the plenum temporale on the superior temporal gyrus. And this is what we did for this patient, the implantation of orthogonal electrodes bilateral. And here is the mapping of the epileptogenic zone, mostly located in the two electrodes on the plenum temporale on the left side, very well demarcated, very well restricted, and several seizures showing exactly the same signature. So it's a very restricted epileptogenic zone located on the superior temporal gyrus on the plenum temporale, with no contributions of the contralateral lesion. So this is just a three-dimensional mapping of the epileptogenic zone located on the dorsolateral aspect of the left temporal areas. And what we performed was an awake procedure. This was his dominant side. Under awake mapping, we performed the resection of the superior temporal gyrus with the preservation of the tip of Heschel's. And this patient had an excellent result with a cortical dysplasia type 2, with mild speech deficits that recovers after 3 months, completely seizure-free after 4 years. So this case illustrates how, even in the presence of lesions, how the discrepancies between the anatomoelectric correlations is a strong indication for invasive monitoring, showing an epileptogenic zone completely contralateral to the EZ, to the lesion. This is another, our final patient here to illustrate also an example of a non-lesional MRI. This is a 17 years old. I will show you the semiological features, seizures asleep. You can see here the initiation of the semiological features with the truncal movements. He's awake. Look, this is semiological, already seizure semiology. He looks around. You can see here the changes in face expressions, very, very clear. With more cycling, he sits, and then a strong scream with some limbic components on it, clearly manifestations of fear with vocalization. So this is 17 years old with several seizures, completely non-refractory. And we believe this patient has seizures only due to semiological features in the frontal polar areas due to the with the manifestation, the limbic manifestations, the vocalization, and also the non-elementary movements in trunk movements that we observe in his semiology. So scalp EEG shows left side frontal polar spikes. The MRI, as I showed to you, completely normal. A PET scan also normal. However, retrospectively, we had to admit that there was maybe some hypometabolism here on the left side superior frontal gyrus. And the ictospect, again, showing the same hypometabolism on the icter spectrum, showing the hyperflow on the left frontal polar areas. So, and again, another MAG scan showing again the presence of bilateral dipoles, but mostly on the left side of superior frontal gyrus, very similar to the icter spect and corresponding again with the semiological features that we observe. So again, there are still some unsolved questions by non-invasive methods. Again, we understand, we are thinking in terms of localization, we are well situated. We believe this is a frontal polar area on the left side, but we still don't know what is the extent of the epileptogenic zone because of the non-lesional MRI features and because of all the questions that we have to answer. In order to address those issues, we perform a very focal SEEG exploration in the left side with orthogonal electrodes focusing on the frontal polar areas in the anterior cingulate and also the orthofrontal. This is the post-op X-ray showing the position of the electrodes. And here is the mapping of the EZ with interictal, very repetitive, very intense, synchronized EZ interictal spikes located on the superior frontal gyrus on the frontal polar areas, a very well-restricted small epileptogenic zone. And this epileptogenic zone was mimicked again by electrical stimulation that confirms the restricted distribution or extent of this EZ. You can see here, this is the stimulation with 50 Hertz. And you can see here the emerging of the semiology with the same electrophysiological features. He stopped reading. He looks around, changing facial expressions.
What is this?
Does not respond. You can see here the changes, the truncal movements. Sits and the screen. So again, very, very similar seizure semiology, confirming that that area very restricted on the superior temporal gyrus was in fact the location of the epileptogenic zone. In this case, this is the location again of the areas very well restricted in the superior temporal gyrus, and because of the restrict extension of the EZ, we decided to perform a SEEG guided laser ablation because of the volume was so restricted. Again, in a completely non-lesional MRI. This patient did quite well, was being seizure-free for almost 6 years at this point with very good results. So again, in conclusions, I would like to emphasize, again, to discuss with you the role of invasive monitoring. Again, the goal here is to the localization, but also very important, and many times we forgot, the extent of the EZ. We know sometimes the localization, but we don't know what is the extent of the EZ, as I illustrate in this last case. So those are the main indications for invasive lesions. They don't correspond necessarily to the EZ in many times, so be careful with those red flags that I illustrated before. Again, in non-lesional cases in general, the utilization of invasive monitoring is in general required. And again, for last, I would like to emphasize the methods of invasive monitoring. What is the best method to use is controversial. However, in order to map the extent of the three-dimensional aspect of the EZ, we like to perform SEEG, and perhaps with the superficial epileptogenic zones in very, very close location with the speech areas. Many times we use invasive monitoring with the subdurals in complement with the SEEG. With that said, I would like to thank again all the participants in my group and also the audience, and I'll be open for any questions. Thank you.